At swallowsafe.com/education, we are a CEU provider with courses that cover a wide range of topics. These courses are available to anyone, but also provide clinicians with the continuing education opportunities they need for relicensure. We get questions about some of the terms and topics in those courses, so at Science in a Sec, we're here to give you a little more information. This one is personal. In 2018, my neck finally gave way. After years of repetitive stress and discs that had been slowly wearing down, my cervical spine collapsed. It was a process 9 years in the making, but the end came in a mundane moment. I was sitting on my couch, working on my laptop, and simply looked up at the TV. In that instant, I heard and felt everything break. It sounded like sheets of glass being pulverized in a trash compactor, the sound of cushioning discs in my neck literally liquefying. As a neuroscientist and medical professor, I had spent a decade teaching doctors and nurses about the brain and motor disorders. But nothing in the textbooks prepared me for the reality of living with one. Nearly 30% of my spinal cord was crushed right where my neck meets my shoulders. The resulting paralysis didn't just affect a single limb, it took over the entire upper left side of my body and parts of my right. It impacted my arms, my neck, the way I spoke, and even functions I had never even thought about, like my heart rhythm and my swallow. Paralysis is often more complex than people realize. We tend to think of it as a total permanent loss of movement, but it actually comes in many different forms and degrees of severity. I have lived with the resulting motor disorders for 5 years now. While the journey has been grueling, I've regained much of my function thanks to the incredible support of my family, physicians, and therapists. I truly wouldn't be where I am today without them. In this article, we're going to look at some common motor disorders. Because these conditions are highly specific to each person and can sometimes be incredibly subtle, they aren't always easy to understand at first glance. We will provide an overview here with links to the deeper Science in a Sec discussions for those who want to learn more. So let's dive in. What are motor disorders? Motor disorders are brain and nerve tissue issues that disrupt how you move your body. The problem isn't a lack of muscle strength, but rather a glitch in the wiring. These disorders generally fall into two categories: hyperkinetic, where the body moves too much, like shaking or jerking, and hypokinetic, where the body moves too little, leading to stiffness or slowness. Movement is managed by three main brain centers working together. The motor cortex acts as the boss, sending the initial go signal to your muscles. The basal ganglia acts as a filter, stopping unwanted extra movements from slipping through. The cerebellum is the finisher, smoothing out your actions so you stay balanced and coordinated. When any of these centers fail, the body's movement goes out of sync. If you are looking for more detail on these concepts, check out our other Science in a Sec articles. We're building a library of easy-to-understand discussions with the hopes that this will give you what you need to use this information in your everyday life. I recommend Science in a Sec, What is a Neuron?, where we cover the fundamental structure and function of a neuron, as well as introduce the concepts of neurotransmitters, the synapse, and transmission. Science in a Sec, What is a Neurotransmitter?, where we go into further detail about what neurotransmitters are and talk about some of the key neurotransmitters most people know about. In Science in a Sec, what are the central nervous system and the peripheral nervous system? we give you an easy to understand explanation of the difference between the central and peripheral nervous systems and talk a little bit more about the parts of the body involved in each of these systems. We will look at each of the brain centers involved in motor disorders later in this article. For right now, let's look at some examples of common motor disorders. These are 12 common motor disorders. DCD, also known as clumsiness. It usually starts in kids, and it makes everyday things like tying shoes or sports much harder to learn than for other kids. Tic disorders. Quick, sudden movements or sounds that a person can't really stop, like in Tourette's. Cerebral palsy. Movement struggles caused by a nervous system injury before or during birth, and it often makes muscles feel very tight or floppy. Dystonia. When muscles lock up or twist into awkward positions on their own. Ataxia. Here, the brain sends the right signals to the body, but the muscles don't work together smoothly, often resulting in movements that appear clumsy or drunk. Apraxia. The motor system has troubles with planning and sending signals to the body to carry out movements. Amyotrophic lateral sclerosis, known as ALS. Often called Lou Gehrig's disease, it's a progressive and gradual breakdown of motor neurons, causing them to die. ALS affects gross and fine motor skills and is devastating to basic life functions like swallowing or breathing. Parkinson's disease. A brain change that makes people move very slowly, feel stiff, or have shaky hands. Huntington's disease. A genetic condition that causes wild, dance-like movements that the person can't control. Multiple sclerosis. An autoimmune disorder where the body attacks the fatty coating around neurons and nerves of the central nervous system, while the peripheral nervous system is preserved. The loss of function can be temporary or progressively permanent. Cancerous tumors. Tumors that grow on areas of the central or peripheral nervous system, like the brain or spinal cord, and can disrupt function in a local area or span a large portion of the body. Paresis or paralysis. This is a partial or total loss of function that can be temporary or permanent. A person may have trouble doing everyday tasks like walking or dressing themselves, or have trouble with more automatic tasks like eating or digesting their food. Now I'm going to take this list and give you a short summary about each disorder. Developmental coordination disorders, DCD, can look like clumsiness. Think of developmental condition disorders, DCD, as a software issue between your nervous system and your muscles. It isn't about a lack of strength. Instead, the nervous system struggles to coordinate the specific steps needed for smooth movement. This can look like general clumsiness, bumping into walls, or it can manifest with troubles like sequencing tasks, such as organizing a backpack or neatly forming letters on a page. Because this wiring issue affects how the brain handles sequences, it often overlaps with attention deficit hyperactivity disorder, ADHD, dyslexia, or messy handwriting. Clinicians diagnose DCD when a child's coordination lags significantly behind their peers and makes daily chores like getting dressed a constant struggle, assuming there isn't another medical cause like cerebral palsy. You can't simply practice away a motor disorder, though improvement still requires plenty of effort. It takes a cohesive plan from a team of healthcare professionals to tackle the disorder from different angles. For instance, Physical therapists focus on smart workarounds, like using Velcro shoes or switching from pens to keyboards. They also teach the plan, do, check strategy, where you talk yourself through a physical action to help your brain build a conscious map of the movement. Since everyone needs to eat, speech pathologists provide real world strategies to manage swallowing issues and make mealtime more enjoyable. Effort, retraining, compensatory techniques, and a supportive environment are essential to recovery. I don't know anything about tic disorders. What is this? Tic disorders usually begin in childhood as quick, repeated movements or sounds. Before a tic occurs, most people feel a restless urge, similar to a buildup before a sneeze, that only fades once they perform the action. Clinicians categorize these based on timing and type. Tourette syndrome involves both physical and vocal tics lasting over a year. If only one type persists that long, it's a persistent tic disorder. If tics are new and haven't hit the 1-year mark, they are called provisional, as many simply disappear on their own. Tics range from simple actions like blinking or throat clearing to complex ones like repeating words or touching objects. Inside the central nervous system, the basal ganglia acts as a gatekeeper that usually filters out accidental movements. In people with tics, this filter leaks, letting unwanted signals slip through the muscles. Because this same area manages focus and habits, tics often appear alongside ADHD or obsessive compulsive disorder. For more information on the CNS and peripheral nervous system, known as the PNS, see Science in a Sec, What are the central nervous system and the peripheral nervous system? I knew a kid in school with cerebral palsy. Cerebral palsy is a lifelong condition that makes it hard for a person to control their movement and posture. It happens because of an injury to the brain while it is still developing, mostly before or during birth, though sometimes in the first few years of life. The most important thing to know is that while the physical symptoms might change as the child grows, the actual brain injury is one and done. It doesn't get worse over time. Clinicians usually group CP by how it affects someone's muscles. The most common version is spastic CP, where muscles feel stiff and movements look stuck or jerky. Others might have dyskinetic CP, which causes shaky or twisting movements they can't control. Or ataxic CP, which mainly makes it hard to stay balanced or be precise. Depending on where the brain was hurt, it might affect just one side of the body, the legs, or all 4 limbs and the torso. Because the brain does so many things all at once, CP often comes with other challenges like trouble speaking clearly, hearing or vision issues, or seizures. However, it's a total myth that CP always affects intelligence. Many people with CP have average or high IQs, but just struggle to get their bodies to follow the brain's orders. Since there isn't a cure, the goal is all about independence. Doctors use a scale from level 1, which is walking freely, to level 5, like needing a wheelchair, to help figure out what kind of support or tools a person needs to live their best life. You've probably never heard of dystonia. Dystonia is an issue in one of the movement control centers we've been talking about, the basal ganglia of the brainstem. The brainstem is also going to be vital in understanding Parkinson's disease and Huntington's disease, which we cover later in this article. Think of this brainstem area as a volume knob for your muscles. In a healthy person, when you decide to move a finger, the motor system turns the volume up for that finger and mutes everything else. With dystonia, that muting function fails. Instead, the volume stays high for multiple muscles at once, forcing them to fight each other and causing the body to twist or pull into awkward, uncontrollable positions. This can happen in just one spot, like the neck or eyelids, or spread across the whole body. Sometimes it only shows up during a specific, highly practiced task, like a writer who can use a fork perfectly fine, but whose hand cramps the moment they pick up a pen. A strange but helpful quirk of the disorder is the sensory trick, where a simple, light touch to the face or neck can momentarily trick the brain into resetting, causing the muscles to relax. Because the problem is about faulty signaling rather than physical damage, treatment focuses on blocking those bad signals. Physicians often use Botox to temporarily relax specific muscles, or in more severe cases, they use deep brain stimulation to override the signaling problems. Apraxia is more common than you think. Apraxia is a disorder of motor planning that makes it hard to carry out familiar physical tasks. Even though the person has the strength and the desire to move, their motor system struggles to send the correct information to their muscles. This motor planning issue can make it difficult to wave hello, use tools, or follow the right steps to get dressed. It can also affect speech or fine movements like buttoning a shirt. This usually happens due to damage from a stroke or injury, though some children are born with it. Because there is no simple medical test, clinicians diagnose it by watching how a person performs specific actions. While there is no cure, people use physical or speech therapy to retrain their nervous system and learn new ways to stay independent. I saw on social media that many of Bill Nye's family have ataxia, and he is a big advocate, but I don't know what it is. Ataxia is a condition characterized by a lack of muscle coordination, typically caused by damage to the cerebellum, the part of the brain that controls balance. This can result in symptoms such as slurred speech, an unsteady gait, and difficulty with fine motor tasks. To review what gross and fine motor skills are, or an overview of the motor system, see Science in a Sec, What are the Central Nervous System and Peripheral Nervous System? Later in this article, we'll be giving you some more information on the command systems of the motor system and essential body parts to know. Ataxia can be acquired through factors like stroke or injury, be hereditary, or have unknown idiopathic causes. Diagnosis involves neurological exams and potentially imaging scans. While some forms are reversible, management often includes therapies like physical, occupational, and speech therapy to help with strength, balance, and independence. Scientist and TV celebrity Bill Nye the Science Guy talks about how ataxia is prevalent in his family and his family's journey. Like me, he knows a lot about the science of this disorder, but it hits different when it's your family or yourself. In our Substack article, we show his story. Like I said, it's personal for so many families across the globe. Amyotrophic lateral sclerosis, ALS, also known as Lou Gehrig's disease. ALS is a fatal condition causing the nerve cells controlling voluntary movements to die, leading to progressive paralysis, while typically leaving senses and mental function intact. Most cases are random in adults aged 40 to 70, with about 10% being genetic. Currently incurable, the average life expectancy after diagnosis is 3 to 5 years. However, treatments and supportive care can help manage decline and maintain independence. Many of the therapy techniques discussed near the end of this article can be helpful to manage ALS. You might know someone with Parkinson's disease. Parkinson's disease happens when deep-seated nerve cells stop making dopamine, a chemical that is essential for movement. You usually don't even notice anything is wrong until about 80% of those cells are already gone. Without that dopamine, it's hard to start moving and even harder to stop unwanted shaking. We discussed dopamine and the basis of neurotransmitters in the article Science in a Sec, What is a Neurotransmitter? We highly recommend reading this article because you can get a good sense of what neurotransmitters like dopamine are and how they impact all functions. Physically, Parkinson's disease shows up in four main ways, often called TRAP. Tremors, which are shaking while you rest. Rigidity, or stiff muscles. Akinesia, moving in slow motion. And poor balance. Beyond just moving, it can also change a person's mood, mess with their sleep, or make their face look masked because they can't control the tiny muscles used for expressions. Parkinson's disease most often affects older adults, but it can affect younger people under certain circumstances. While there isn't a cure yet, doctors use a drug called levodopa to refill the brain's dopamine levels. For more advanced cases, they can even install a brain pacemaker called deep brain stimulation that uses electrical pulses to smooth out the signals and get the body moving properly again. Huntington's disease is a genetic motor disorder. Huntington's disease is a rare condition passed down through families that act like a mix of Parkinson's disease, ALS, and dementia. It's a strictly genetic disorder caused by issues in a single gene called the Huntington gene on chromosome 4. If a parent has this gene, their child has a 50% chance of inheriting it, and anyone who carries the gene will eventually develop the disease. Patients are often between the ages of 25 and 45. Inside the motor system, this genetic change creates a toxic protein that kills off cells in a region called the striatum of the brainstem. Think of the striatum as the brain's brakes. In a healthy person, it stops movements you don't want to make. In Huntington's, those brakes fail, leaving the body's movement system stuck in the on position. This leads to the disease's most famous symptom, chorea, which is a series of jerky, dance-like movements that the person cannot stop. The disease hits in three main ways: physical, mental, and emotional. Physically, it starts with small twitches that can grow into constant writhing. Mentally, it causes brain fog, making it hard to plan or organize. Emotionally, it can lead to sudden mood swings, irritability, or depression. Over about 15 to 20 years, it moves from minor clumsiness to a total loss of physical and verbal control, eventually requiring full-time care. Multiple sclerosis is progressive, but symptoms can sometimes go away. Multiple sclerosis, known as MS, is an autoimmune disease where the body mistakenly attacks the protective coating around its nerves, disrupting signals between the brain and the body. It causes symptoms like vision problems, muscle weakness, numbness, and fatigue. MS is divided into four main categories that help clinicians decide on the best treatment. The most common is relapsing remitting MS, where patients experience clear attacks followed by periods of recovery. Over time, this often turns into secondary progressive MS, where symptoms stop coming in waves and instead get steadily worse. Some people have primary progressive MS, which declines gradually right from the start without any breaks, while others may experience clinically isolated syndrome, a single neurological episode that might, but doesn't always, lead to a full MS diagnosis. There were also much rarer versions of the disease. These include progressive relapsing MS, which is a steady decline mixed with sudden attacks. Tumefactive MS, where neurological spots look like tumors. And Marburg variant, an extremely aggressive and fast-moving form of the condition. You may have heard of Christina Applegate, a famous actress that was diagnosed with MS in 2021 during the last season of filming her Netflix show, Dead to Me. She spoke to Good Morning America in 2025 about MS and has been very candid publicly about what it's like to go through that battle. We show her personal story in the Substack. Similar to ALS, Parkinson's disease, and Huntington's disease, there is no cure for MS, but a lot can be done to help manage the symptoms. Physicians diagnose MS using scans and exams to look for nerve scarring. Management includes medications to slow progression, steroids for recovery, speech therapy to manage communication and swallowing problems, and physical therapy to help with mobility. Cancerous tumors can also be found in the nervous system. Cancerous tumors can affect the motor system by growing in or pressing on the brain, brainstem, cerebellum, spinal cord, or peripheral nerves. These tumors disrupt the signals that tell your muscles how to move, which often leads to weakness, loss of coordination, or paralysis. Diagnosis typically involves a neurological exam and imaging scans, and treatment often includes surgery, radiation, or chemotherapy, followed by physical therapy. Paresis and/or paralysis. For me, it's personal. Paresis and paralysis can occur suddenly due to events like strokes or spinal injuries, or gradually from conditions like ALS, MS, cancerous tumors, and so on. Temporary forms of weakness include Bell's palsy and Todd's paresis, which follows a seizure. Diagnosis involves neurological exams to grade muscle strength and imaging scans to identify nerve damage. Like so many motor disorders, speech and physical therapy can make strides in regaining strength or learning to use assistive devices. Paresis and paralysis both involve losing muscle control, but they differ in scale. Paresis is partial weakness where you still have some movement and feeling. Paralysis is a total loss of movement in a specific body part, often accompanying by a loss of sensation. These conditions are named based on which areas are affected. Monoplegia involves one limb. Diplegia affects the same limb on both sides. Hemiplegia covers one side of the body. Paraplegia impacts the lower half. And quadriplegia affects everything from the neck down. Doctors also grade spinal injuries as complete, meaning no movement or feeling remains below the injury, or incomplete, where some function is still preserved. I live with ongoing motor disorders every day, and I found my path. That brings me back to my own story. My health issues started slowly, but then everything changed in an instant. I suddenly became paralyzed in some spots and incredibly weak in others. I was fortunate that about 70% of my motor system was still working, which gave me a fighting chance to recover. I did lose some functions forever. It's a strange feeling, like having black holes in my body where I can see a limb moving but feel absolutely nothing, or I can feel it but it just stays limp and won't respond. I know how lucky I am. For the last 7 years, a dedicated team of doctors and therapists have helped me rebuild my life. Only about 1% of people with my specific injuries make it back this far, and I am grateful every day. I dealt with physical, speech, and even emotional challenges that affected everything from eating and moving my eyes to my heart's rhythm. Losing a basic ability you've always taken for granted is one of the hardest things anyone can face. My family and my medical team were my lifeline, helping me accept my own new normal while finding the strength to recover and enjoy life again. If you or a loved one are on a similar path, I highly recommend an article on swallowsafe.com called Having Hope. It was written by Carol G. Winchester, who is a speech pathologist on our team and also my mom. It's a beautiful look at the journey we navigate with these disorders, and you can even listen to it as a podcast. Her perspective, both as a clinician and someone who embarked on this real-world journey with me, could help you or your loved one as they find their way. It is important to remember that of the conditions above, Parkinson's disease, Huntington's disease, MS, and or cancerous tumors can cause paresis or paralysis, but there are so many more. Okay, you've shown me some common disorders, but what is actually going on? When movements go wrong, it's usually because one of these 4 areas is struggling. First, the motor cortex, the starter. If this is damaged, you'll have trouble starting a movement or may feel paralyzed. The basal ganglia, the filter. When this fails, you get extra unwanted movements or stiffness, like in dystonia or Parkinson's. Cerebellum, the coordinator. Issues here lead to clumsiness and loss of balance. Spinal cord and nerves, the cables. If these are disrupted, the message simply can't get from your brain to your muscles. But neurology is so vast and complicated. What are the essentials I need to know? The primary motor cortex, known as M1. The primary motor cortex is located in the frontal lobe, and it serves as the final command center where thoughts turn into physical actions. When you decide to move, this region sends an electrical go signal down your spinal cord to your muscles. This system is uniquely cross-wired, meaning the left side of your brain controls the right side of your body and vice versa. This happens because the nerve fibers, known as cortical spinal tracts, cross over the brainstem. Because this area is the only exit point for voluntary signals, damage from a stroke or injury is usually quite severe. It often results in hemiplegia, that paralysis on one side we talked about, because the muscles are essentially waiting for a phone call from the brain that just never arrives. Even if damage is minor, you might lose fine motor skills. For example, while you could still swing your arm, you might lose fractionation, or the ability to move a single finger independently to type or to button a shirt. Additionally, without the motor cortex to help regulate muscle tension, limbs can become spastic, meaning they feel tight or overreactive to touch. Essentially, when the boss of the brain is sidelined, the body loses both its power and its precision. The basal ganglia of the subthalamic region. We've talked a little about the basal ganglia so far. It is deep inside the brainstem and acts as a high-tech gatekeeper or backstage manager for your body. While other brain regions come up with ideas for moving, this system decides which one of those ideas actually make it to the stage. By using a chemical called dopamine, it filters out unwanted noise, so your motions remain smooth and intentional. We encourage you to see our previous article, Science in a Sec, What is a Neurotransmitter? Because it gives you a great overview of dopamine and other neurotransmitters. We've pointed this out before, and we just think you'd really benefit from it. The system works like a circuit with two main settings, a go signal to start a movement and a no-go signal to put on the brakes. The striatum takes that information while the substantia nigra provides the dopamine fuel to keep everything running. When this circuit is balanced, you can reach for a glass of water with total precision. If this gate gets stuck, it causes motor disorders. In Parkinson's, the brain lacks dopamine, so the go signal fails, leading to stiffness and slow movements. In Huntington's or tic disorders, the no-go filter weakens, letting extra jerky movements or twitches leak through. Beyond this basic movement, this area is the headquarters for habits and rewards. It stores autopilot programs for tasks like tying your shoes and uses dopamine to reinforce behaviors that feel good. However, if these loops get stuck on a loop, it can lead to repetitive behaviors seen in OCD or Tourette's. There are also other complications like cognitive impairments or dementia associated with these conditions. The cerebellum. At the very back of your head is the cerebellum, or the quality control specialist. It doesn't start the movement, it just makes sure you don't look clumsy. It handles your balance and precision by constantly comparing what you tried to do with what you're actually doing. If it's damaged, you might feel like you've lost your rhythm, leading to stumbling or a total loss of coordination. Even though it's your little brain, it holds over half of your brain's nerve cells, all dedicated to making sure your movements aren't jerky or clumsy. M1 decides to move, but the cerebellum handles the how, fine-tuning your timing and balance so when you walk upright, catch a ball, or perform a gymnastics routine without thinking about it. It makes split-second corrections. This is where muscle memory lives, and after enough practice, you can ride a bike or play an instrument on autopilot. It even helps out with non-physical things like your attention span and emotions. Inside, it looks like a folded accordion with a white center called the tree of life that branches out to carry signals. When this area is damaged, whether by an injury or something like alcohol, you lose that precision. This leads to a state called ataxia that we highlighted before, which feels a lot like being drunk. You might stumble while walking, struggle to judge distances, like reaching for a cup and missing it, or find your hands shaking as you try to do something delicate, like threading a needle. Even your speech can become slurred because your brain can no longer coordinate the complex muscles used for talking. The cerebellum and your cortex make up the brain, while the basal ganglia is part of your brainstem. Together with the spinal cord, spinal nerves, cranial nerves, and the peripheral nervous system, movement is possible. So I told you about the command centers. Now let's look at how the commands are carried out. Spinal cord, spinal nerves, and cranial nerves. Your spinal cord is your body's main power line, a thumb-thick bundle of nerves protected by your backbones and cushioned by shock-absorbing fluid. It acts as a high-speed highway, zipping go commands down to your muscles and field data, like heat or pain, back up to your brain. It even handles emergencies on its own. If you touch a hot stove, The cord's reflex arc pulls your hand away before your brain even registers the heat. Branching off this main line are 31 pairs of spinal nerves, the individual wires that connect your skin and muscles. These nerves are grouped by region: cervical for the neck and arms, thoracic for the trunk, and lumbar sacral for the legs. Clinicians use maps of these territories to pinpoint injuries. For example, a slipped disc pinching a lower nerve often causes the shooting leg pain known as sciatica. While spinal nerves handle the body, 12 pairs of cranial nerves plug directly into your brainstem to manage your head, face, and senses, allowing you to see, taste, and move your eyes. The cranial nerves are so special, we will devote an entire Science in a Sec article to discuss them and the importance of therapeutic management. Be on the lookout for that, coming soon. Upper and lower motor neurons. To understand how your body moves, clinicians look at two main types of nerve paths: upper and lower motor neurons. Think of upper motor neurons as the main cables starting in your brain and brainstem. Because these paths cross over, damage here usually affects a large area on the opposite side of the body. Damage to upper motor neurons in conditions like Parkinson's disease, Huntington's disease, paresis, paralysis, or MS, and is often more severe than damage to lower motor neurons. Lower motor neurons are the smaller wires that connect your spinal cord directly to your muscles. Damage to these nerves affects the same side of the body. For example, if you have a knee surgery and lose feeling right around the cut, that is lower motor damage. By tracking which side of the body is struggling, your medical team can figure out where the wiring problem is located. Knowing whether the damage is upper or lower helps them choose the right tests, creating a treatment plan, and predict how much movement you might be able to get back. What would we do if any of this happened to me? Management and support. The first step is to get assessed by a skilled clinician and then begin to work with your interdisciplinary healthcare team. To understand motor disorders, it helps to look at them as a breakdown in a couple complex chains of commands. Each discipline, for example, neurology, speech pathology, physical therapy, and nursing, focus on different links in that chain to help a patient regain function or adapt to changes. When treating motor disorders, healthcare teams work together to bridge the gap between the brain signals and body movements. Neurologists. Neurologists act as the engineers who find where the signal is breaking down, whether it's upper damage in the brain causing stiffness or lower damage in the nerves causing weakness. They use the brain's ability to rewire itself and manage neurotransmitters like dopamine to help the body find new ways to function. Speech-language pathologists. Speech-language pathologists focus on the vital muscles used for talking and eating. For example, in my situation, swallowing was one of the most severe deficits I experienced because my spinal cord injury was in my neck. My brainstem, spinal nerves, cranial nerves, peripheral nerves, and the muscles of my neck and face were all suffering from paresis and/or paralysis. Thankfully, I was immediately assessed for my swallowing issues with a comprehensive evaluation called the Fiber Optic Endoscopic Evaluation of Swallowing, known as FEES. And I received a treatment care plan that worked with my life and slowly began to eat and drink again. The clinical term for swallowing issues is dysphagia. For patients like me or those suffering from any of the myriad of motor disorders, the biggest priority is preventing aspiration, which is when food accidentally enters the lungs. Speech pathologists might recommend thickened drinks or special tools like eye tracking computers to help people communicate and eat safely. I can tell you from my own experience, thickening the food and liquid slowed the entire process down, so the little function I had was able to kick in and keep me safe. I would choke and aspirate so frequently, I had severe bronchitis and was in real danger of going to the hospital at many points in my recovery. My speech and dysphagia team was imperative to stabilizing my nutrition and my health. Thanks to my mom, we were able to find recipes that were enjoyable and dysphagia safe. One of my absolute favorites is this soft, savory turkey dip to enjoy during the big game. Go to swallowsafe.com to learn more about how you or your loved one might be able to manage their dysphagia, and check the seasonal feast section for yummy recipes that are safe for anyone dealing with swallowing issues. We also have the Swallow Safe podcast on YouTube, Substack, and Spotify. In episode 2, Mom and I talk a lot about how personal dysphagia can be and why the seasonal feasts can be so helpful. You should check it out. Physical therapists. Physical therapists handle big movements like walking and balance. They help retrain the brain to store new muscle memories and manage muscle tightness so joints don't lock up. Crucially, they also work on core strength. For example, if you can't sit up straight. Nurses. Finally, nurses provide daily frontline care. They ensure medications are timed perfectly so muscles don't freeze, and watch for safety issues like pocketing, where food's getting stuck in the cheeks. They can make referrals to the speech and physical therapists if any of these issues occur to get you on your journey to recovery as safely as possible. They also prioritize oral hygiene and skin care to prevent infections and bed sores, making sure the overall treatment plan works in the real world every single day. It's personal. Motor disorders are more common than most people realize, but they rarely get much attention until they hit close to home. In today's Science in a Sec, I shared my perspective as both a neuroscientist and a patient living with a motor disorder. While I understood these conditions academically, nothing prepared me for the reality of actually experiencing one. I was incredibly fortunate to have my mother by my side. Beyond her support as a family member, her expertise as a speech pathologist gave us a roadmap for the recovery process. This is why we've poured so much into SwallowSafe.com. We know this journey is deeply personal, and we want to show that there is always a path forward. Recovery starts with the right assessments, a dedicated, multidisciplinary healthcare team, and a supportive environment. In this series, we'll be breaking down specific motor disorders into their own articles, offering more detail and linking you to the resources and community support available at swallowsafe.com. You don't have to navigate this alone. Thank you for spending this time with me today. If you are a clinician and are looking for continuing education opportunities, SwallowSafe.com has CEU courses available. For example, we have a great course on the neurological system and how it relates to dysphagia. Don't forget to follow us on all your favorite social media platforms. Facebook at swallowsafe.com, Instagram, swallow.safe, LinkedIn, swallowsafe.com, X, swallowsafe_com, TikTok, dysphagia_safe, Substack, swallowsafe.com, or Spotify, swallowsafe.com.